As usual, we don't have any financial disclosures.
Our objectives overall today are to talk about how we recognize upper airway conditions in pediatric patients. We'll talk about some of the interventions that we can do when patients present with these emergencies. And then finally, we'll talk about what our parameters are for transfer of these kids with upper airway conditions. So I can't take credit for this framework. Dr. Tzimenatos, as we were working on this presentation, started us off with this framework. And so I think every time we can take an approach of something in a systematic way, it's helpful to have that to latch on mentally for me in terms of kind of what are the different categories of things that I'm thinking about. And so the different categories that we identified are congenital, infectious, foreign bodies, anaphylaxis, and trauma. On the right-hand side, you can see that we have a diagram of the upper airway. It was funny as I worked through some of these, trying even myself to debate which ones I was going to still consider limited to the upper airway versus some of them kind of involve both the upper and the lower airway in terms of both their symptoms and the pathology. So we'll talk through that a little bit today. We're going to talk through infectious and foreign bodies. We'll talk a tiny bit at the end about congenital causes. And then we can see where our discussion takes us. We're happy to talk more about anaphylaxis and trauma, but won't cover that in this part of the presentation. So in terms of infectious, the four categories that we identified were croup, which is definitely, we've been seeing a lot of that lately, and having a lot of kids, both the younger and toddler age, with symptoms of croup presenting. Some of the other ones that we see probably a little bit less commonly include bacterial tracheitis, epiglottitis, and a retropharyngeal abscess, or along with that, I would also say peritonsillar abscess. And so for each of these patient populations, we're going to talk through a little bit of kind of the highlights of the things that we might think about and the populations that we might see it in.
And we were going to start with croup. I think it's probably of these conditions that we're talking about, the most common upper airway condition that we see in pediatric patients. It also has one of the broadest ranges of clinical presentations, with some children presenting very, very mild and then others with a more severe presentation. One of the things I think that I like about croup is that it's still one of those conditions that we can diagnose clinically. So based mostly on your history and your physical examination, we don't really need other testing. The kids usually present with pretty characteristic upper airway edema, and it causes that really characteristic barking cough. So, barking like a dog or like a seal is usually how I kind of ask the family about it. These kids will often have stridor. Most of them will have it with agitation. Some of them will have it at rest as well, and we'll talk about that a little bit. And then typically there's sort of some URI symptoms that have preceded this, or sometimes it seems like it kind of does come on all of a sudden. Most often at night, I feel like families are bringing patients in, and it's like they didn't really notice cold symptoms, and all of a sudden a child woke up coughing, and then they do have, some rhinorrhea, congestion. Sometimes they'll be febrile at the time and come in with those symptoms. It's also particularly easy to do it during the times when it's more common. So it's interesting because fall has sort of traditionally been the time that we see parainfluenza and our highest number of croup. But I think, as with many things post-COVID, our timing has shifted around, and now we see it a lot in general, and certainly more frequently. The Wesley Croup score, which is listed on the right-hand side of the screen here, is a way that we can objectively look at kids who have croup. It's a validated score that we can use to assess their severity, and it uses level of consciousness, cyanosis, stridor, how well they're having air entry, and then their degree of retractions. And again, it can be helpful to sort of give us a framework for thinking about how we're assessing these kids. I'll tell you kind of on the next slide that I tend not to use it in terms of my sort of working management of croup, but I think it is helpful to think about in a couple of different ways. And then, because other things can mimic croup, or you can think croup can mimic other things, there are times that we do want to go beyond our history and physical exam and think about other diagnostic modalities in these kids. For me, typically, I'm doing that if the kids are critically ill. So if they come in with extreme respiratory distress, particularly if they're cyanotic, and if their consciousness is altered, because those are things that tend to happen so late in croup that my thought is either that I'm dealing with an incredibly severe case of croup or I'm dealing with something else. or children who don't respond to the therapy that we use for croup the way that we expect them to. So in those kids, we're thinking about some of those other infectious etiologies. Like epiglottitis, bacterial tracheitis, especially if they're having that kind of barky cough and stridor. I'm also thinking about foreign body if they're in sort of that age group or if they don't have an infectious type of history. And then those kids, depending on what it is that I'm concerned about, then either screening labs, looking at CBC inflammatory marker types of picture, or chest x-ray or lateral neck films. Any of those can be helpful depending on what you're looking for.
Yeah, I think what's interesting is like the classic is para-influenza, but I think the other piece of that is we see a lot of kids who may present with croup-like symptoms that now that we're doing so much viral testing, we have other viruses that can also be culprits in terms of croup.
Also interesting because I feel like for a little while there, we were seeing croup associated with COVID. And I think that as the strains of COVID have changed, I haven't seen that as much as I was in some of our previous times, but I'm still thinking about it. And so point of care viral testing, I definitely am doing in these kids. And then I think the more extended viral testing is usually saved for kids who are more severe and getting admitted to the hospital. So I actually kind of also like the management of croup because I feel like in my mind it's pretty straightforward. If someone comes in with really any severity of croup, I am going to plan to treat them with the dose of dexamethasone, and that's based on multiple studies that have been done over the years. And since there have been multiple studies, there have also been like some Cochrane analysis and some meta-analyses that have shown that dexamethasone can help to shorten the course of croup. It can also help to decrease severity in terms of some of the validated scale, like the Wesley score, and it's been shown to decrease return visits to healthcare. So it's in my mind, mild, moderate, or severe croup is great to be treated with dexamethasone. So if someone has a croupy cough, if the family says this sounds just like when his brother had croup, even if I'm not hearing the cough, I have a pretty low threshold for giving a single dose of dexamethasone. For the kids that are mild and are only presenting with that barky cough and potentially stridor with agitation but not at rest, then they can get their dose of Dex. We usually get a couple sets of vital signs, and then they're ready for discharge home. It's often not a long ED stay. It's a little bit different in kids who are presenting more severe, and the kind of breakpoint that I use for that severity is kids who are having stridor at rest. So um, if they are, then we will treat them with additional modalities, and the main one that we use is racemic epinephrine. And so kids tend to have a very good response to that, especially if it is viral croup. Their airway edema responds pretty rapidly, and often by the end of the treatment, that stridor at rest will be gone. The other thing that's key in our kids who are more moderate or severe is to keep them as calm as possible. We know that agitation tends to worsen their upper airway symptoms. It can make them look worse and feel worse, and then that can kind of spiral, especially if they're getting more agitated and panicked. So in the ED, that looks like keeping the kids in their parents' lap. Some of the things that we try to do anyway in terms of keeping children comfortable, but we'll also postpone sort of the more noxious components of our initial exam if we need to until the child's been treated. So things like an ear exam, I won't do on these kids when they first come in. Rectal temperatures we'll try to avoid until later, or just do axillary temperatures instead if we can, so that we're kind of keeping the child as calm as possible. And then if they respond to the racemic epinephrine, they've gotten their dose of Dex and their stridor has resolved, then we're able to observe them. And typically we do that for about 2 or 3 hours, the idea being that we want to observe them through the time that the racemic epinephrine is wearing off. And it's not one we can send the kids home with. So if they're needing it in a recurrent manner, we'll want to keep them in the hospital. Whereas the more severe kids, again, the ones that are either a lot worse when they first come in or who are not responding as well, then I want to sort of monitor them carefully, continue to keep them as calm as I can, and really sort of think about what my next steps are going to be if this is a child who's going to need more airway support. So things like Heliox, which can be used, so helium and oxygen mixed to kind of decrease airway turbulence, can sometimes be helpful in these patients, or thinking about intubation, and again, sort of thinking about what we would have to do different in a child where we suspect that croup or upper airway obstruction is the reason for their respiratory distress. And then again, the majority of our patients who come in with viral croup look pretty well when they get there, with the exception of those, sort of really severe respiratory distress kids. They typically, aren't really ill appearing with high fevers. And so if we're seeing kids that are on that more toxic spectrum, then we think about bacterial infection sooner rather than later in that group. So in my mind, there's kind of two categories of these. There's the ones that still sort of look croup-like. So those are the ones that could still have the barky cough, still have stridor. Voice changes I have listed in this left-hand column. I think it probably fits with both of them actually, but sort of in different ways. I feel like our kids with bacterial tracheitis and epiglottitis can present with sort of a hoarse voice, and again, typically more ill appearing than what we see in our viral croup kiddos. They The plain films can be helpful for distinguishing these. Epiglottitis, the sort of textbook is that thumbprint sign, so the thickening of the epiglottis on a lateral soft tissue neck X-ray. That one's a little bit tricky because if the kid is rotated at all, which you can imagine trying to get a lateral neck film on a squirmy, ill-appearing toddler is going to be tricky. And so if they're rotated, it can make the epiglottis look thickened, even if it's not. So we sometimes get some false positives on these X-rays. And then bacterial tracheitis, we tend to see sort of thickening and a pseudomembrane along the trachea, which can be seen either on the chest X-ray or the lateral neck. And again, I list these plain films as sort of a diagnostic modality, but it's interesting because I just said I also try not to agitate these kids. And so it's one of those, if they're really ill appearing and I'm worried about one of these things, X-ray doesn't need to be first on your list and isn't usually first on mine, but I'm sort of thinking about, can I fit this in to get more information, as I'm also thinking about sort of therapeutics and how to treat the child. And then on that right-hand side, symptoms that, oh, Heather, were you going to add to that?
Yeah, I was just gonna say, like emphasize what you had said. I think for that left-hand group, usually those kids are very ill appearing. And the kids that I've seen those in my career have been kids who were American Indians who had untypable H flu, and on their initial presentation have a very toxic appearance. So both tenuous in terms of their airway and like their respiratory status, as well as just very ill appearing.
And then sort of that other category of kids are kids who are presenting with sort of more oral symptoms, so sore throat, drooling, difficulty swallowing, and then often neck complaints as well. So either sort of a sore throat, pain in the anterior neck, or pain in sort of the posterior neck. So in those kids, thinking about retropharyngeal abscesses with kids, especially presenting with sort of refusal to want to move and flex their neck, as well as peritonsillar abscesses. If we're suspecting retropharyngeal abscess, plain films can be helpful to start with because they can show some thickening of that prevertebral tissue. But typically, we end up having to go to CT scan, partly for surgical planning if it looks like there's going to be something to drain, as well as just to be able to more definitively make the diagnosis. So if I have a high suspicion, I would go right to CT scan in this group. Whereas if I'm doing a little bit of screening, the X-ray can be helpful. And then peritonsillar abscess, we can usually make that diagnosis clinically. It's most often in older kids, so they're a little bit more cooperative with the exam. They can give a little bit better history, a more specific history about sort of what their symptoms are doing. And then you can see that characteristic soft palate swelling when you examine them. So we have foreign body listed as our as the next topic that we wanted to cover. And again, we're talking about upper airway conditions. And so it's kind of funny that we have esophageal foreign bodies on here. But sort of just thinking about where foreign bodies can go when kids ingest or aspirate them. It can start sort of, obviously it starts in the oropharynx, and then whether it sort of stays there and gets lodged superiorly, or whether it gets aspirated and goes down to the trachea, or gets swallowed during that choking event and goes down into the esophagus, just sort of depends on I think the nature of both the foreign body and the episode and the age of the child. But we do list esophageal foreign bodies here because just based on real estate, having something that's good sized in the esophagus can impinge on the airway, and they can present with some of those same symptoms. So keeping in mind that even though it's not in the airway, it's still obstructing or affecting the airway. This is the sort of the paradigm that I use for when we suspect a foreign body, and almost always it sort of hinges on a history. So a history of a choking episode, either with a known item that either a child was eating or was playing with, or was seen to put in their mouth. And if the family sort of recognizes that, there's really good evidence that a good history can be very sensitive for detecting foreign body in children. And so even in the absence of some of the other elements, having a child who's having sort of any respiratory symptoms in the setting of a history of a choking episode or concern for foreign body, we really think about looking further. And so what that looks like at UC Davis is that we typically end up consulting ENT if they have at least a positive history. And then if they have either abnormal findings on their exam or abnormal X-ray imaging, then that just sort of adds fuel to the fire. And I think that adds a little bit more pressure for ENT to help us in terms of looking farther for that foreign body. But even a history alone will get us consulting ENT. There's some places and some sort of times, some situations where it can be helpful for ENT to do a bedside nasopharyngeal scope to look for foreign body. It's a pretty small subset of patients that are going to qualify for that based on sort of the pediatric group, right? Because you want to have a child who's cooperative enough that they can do it, and a foreign body or a situation enough where you think that that's not going to make the situation worse. So really, the gold standard for evaluating for foreign body in pediatrics is rigid bronchoscopy, and so that's most often done in the OR because it can be diagnostic to find the foreign body. They're also able to remove it, and the whole thought is that this is in a much more controlled environment where they're able to control the airway as they're doing all of this. So even though I feel like it's kind of a small part of our pyramid there, because X-ray findings are not always specific, not always present in kids who have foreign bodies. If it is abnormal, it can be very helpful. So a couple of examples here. The one on the left is kids who swallow radio opaque foreign bodies are probably the, most helpful of our patients because they are the easiest to find. So a coin in the esophagus is what you're seeing on that left-hand side. And that's typically the way the coin is oriented when it's in the esophagus. Coins in the trachea are oriented 90 degrees to that. So you actually just see them in sort of the thin side on that AP film. And that has to do with the tracheal rings and how things kind of fit. I've seen them in textbooks. I have not in real life seen a coin in the trachea, and I think it's because the kids are not stable enough to be getting plain film X-rays, if that is the location of that foreign body. And then on the right-hand side, what that X-ray is showing is it's showing some asymmetric air trapping in a child who had a tracheal foreign body that then sort of migrated to one side. So in this case, it migrated to the right main stem bronchus and is having that ball valve sort of physiology where it's letting air pass on inspiration, but then as it's getting pushed up against the sort of more narrow part, it is not allowing air to be exhaled the same way. So they have increased air on the affected side compared to the unaffected side. For kids who are cooperative enough to do inspiratory expiratory films, you can get sort of an exaggeration of that air trapping on your expiratory films. But again, in our patient population, that's not usually that cooperative age group that are the ones that are aspirating foreign bodies most often. So the same way you can actually get bilateral lateral decubitus film. So you basically get films of the child laying on each side, and gravity will usually push the mediastinum down towards the dependent side. But if you have air trapping, it will stop it, and so it will still look larger even when it's dependent. So it's one that we don't do often enough that I feel like our radiology techs are used to it, and so I often will get phone calls when I order my bilateral decubitus film, chest films. But once we explain what we're looking for, it makes sense, and then it can be helpful in identifying that.
And then just briefly to touch on kids with some kind of congenital malformation. In contrast to our kids who have an infection, these kids are usually stable. But I will say we have a fair number of kids. Usually, this is a population of kids that's less than a year of age. They often come in and present with feeding difficulty. So the family may give a history of just having it be very challenging to get them to feed. And then also when they do feed, they may have a history of choking. Some of these kids have enough difficulty feeding that they may also have poor weight gain. Um, but it's not unusual for the population that we see where they've come to their primary care more than once regarding the concern, and then even potentially presented to an emergency room. And so for these patients, it can be tricky to sort out because we have kind of our young population who may present with physiologic spitting up and trying to sort out what kind of elements are you hearing. And some of those kids even if they're being overfed or um, occasionally can have some choking or things with just normal physiologic spitting up. But for these kids, you're usually going to get a really consistent, persistent concern from the family that it's always difficult to feed, and that things have been difficult for quite some time. And so the different things that we think about for some of the ones that are more pathologic are the last three. So for those tracheoesophageal fistula, sometimes with that, you'll also get a history that the kid is having nasopharyngeal aspiration. And then when they spit up, oftentimes they may report that it comes out the nose, and it just looks like formula. For kids who have a vascular ring or sling, most of those kids that I've seen have presented with that story that I've described of choking. And oftentimes we'll end up diagnosing it either on an upper GI or on an echocardiogram. And then finally, cleft palate. In the newborn nursery, we try to screen all kids for a cleft palate, but especially in the soft palate, can be hard to recognize. And so it is indeed the case that some of these kids, it's easier to miss, and that they may be a kid that's having difficulty with feeding because of that. And now I'm going to go back up to the top one. So we see a lot of kids with laryngomalacia early on. The vast majority of kids, it's a relatively benign condition, and kids, as they get bigger, tend to grow out of it. Um, the history or the way that I think of these patients is that they're squeaky breathers. So oftentimes when they're just chilling out, even like when they're awake, sometimes when they're asleep, certainly like if they get upset, the upper airway is just more floppy. And so you can get that squeaky sound. Typically, as opposed to like a patient with croup, most of these patients don't have distress. Occasionally, some of these kids will have more severe condition of laryngomalacia and have more prominent airway collapse. And so there is a small population where ENT may intervene, but the vast majority of this patient population, um, it's relatively benign and those kids grow out of it.
And then we wanted to talk just a little bit about disposition on these patients. So, in terms of admitting or transferring them, depending on what level of care that you have available at your hospital. And this is one that I think that we struggle with a little bit from our emergency department too. It's sort of, how long we watch these kids in the emergency department, how they need to respond, and then even our level of care decisions for ward versus ICU level of care, I think, is a little bit softer in these kids compared to some of our more protocol based decisions that we make. But in general, I think that kids who are having persistent or recurrent respiratory distress, and I include stridor at rest in that, are kids that need to be watched for longer. Again, we don't have the same options for short acting treatments at home for these patients. So if the dexamethasone is not yet kicking in or is not what they need to do the trick, then having them where they can be monitored and can get that short term treatment more often is important. Um, I think also if there's a concern for some of those alternate diagnoses that we talked about. So if you think that this could be one of those bacterial processes and the kids have the potential to worsen quickly, if there's concern for the possibility of a foreign body, then those are things that we want to think about having those children evaluated by subspecialists. And so if those aren't available, then transferring them to where that can be done. And then the congenital abnormality that Heather was just talking about, I think that those can, kind of complicate some of these other things. So we've had I know recently in the emergency department, we've had a kid who has come back a couple of times who probably has some underlying laryngomalacia. And so when he comes in with respiratory symptoms, it sounds very much like severe croup. And so we're sort of in this struggle of how are we managing his chronic or his acute findings? And it just makes it tricky enough that I think that having him in-house where we do that, or having him in a place where, again, there are subspecialists or people who are sort of used to dealing with these more complicated cases, can be helpful.